All right, so welcome to our featured lecture today, Recommended Vaccines for Long-Term Care Residents, brought to you by the Michael Garron Hospital IPAC Hub and the Center for Vaccine Preventable Diseases. My name is James Callahan, and I'm the supervisor of the IPAC Hub here at MGH, and I will be your moderator today. Let me introduce you to our speakers. First, we have Dr. Ramandip Grewal, who is an associate professor at the Center for Vaccine Preventable Diseases and the Dalla School of Public Health at the University of Toronto. She is also a scientist with Public Health Ontario. Dr. Shelly Bolotin is the director for the Center for Vaccine Preventable Diseases and is an associate professor at the Lana School of Public Health in the Department of Laboratory Medicine and Pathobiology at the University of Toronto. She is also a scientist with Public Health Ontario. Before we begin, I want to take a moment to qualify who our target audience is and what we hope to achieve here today in our role as the IPAC Hub. So within our scope of practice, it's to provide guidance and support to those who are responsible for infection prevention and control programs in long-term care homes, retirement homes, and congregate living settings. We're happy to coordinate this learning opportunity, and it's been specially designed for IPAC leads who are responsible for obtaining consent and facilitating the administration of routine immunizations in these settings. We've heard from multiple IPAC leads that they've faced some resistance from substitute decision makers and residents in long-term care while advocating for these routine immunizations recommended for long-term care homes. A common concern we've heard from families is that they've had enough COVID vaccines in the last 3 years, or that their loved one doesn't need a vaccine for something that they have an illness that they haven't really heard about. And the fact of the matter is, pneumococcal disease, influenza, RSV, and shingles can cause significant morbidity and mortality in these populations. As the IPAC Hub, we recognize the opportunity for education here, and our IPAC leads are also asking for this education. So if you, today, as the IPAC lead responsible for immunization within your organization, leave here today feeling more confident in your understanding of these routine immunizations and feel more equipped to advocate for these safe measures, we'll have achieved our goal. And with that, I'd like to hand it over to Dr. Grewal and Dr. Bolotin.
Thank you so much for the lovely introduction, James. I'm just going to share my screen. Hey. So as James mentioned, we're going to talk a little bit today about the recommended vaccines for long-term care residents. And so as also mentioned, I'm Ramandip, so I'll start off the conversation today. So just a quick overview of what we'll chat about today. So we'll go over some of the vaccines that are recommended for long-term care residents, specifically pneumococcal vaccine, COVID-19 vaccine, influenza, RSV, herpes zoster. And we'll go a bit over how the vaccine works and why it's important for long-term care residents, vaccine safety, immunogenicity, effectiveness, efficacy, if it's available, as well as the guidelines in terms of recommendations and then the available programs in Ontario. So I'll start off by talking about pneumococcal vaccines. So Streptococcus pneumoniae is the cause of pneumococcal disease, including community-acquired pneumonia as well as invasive pneumococcal disease. And there are a number of different distinct serotypes of the bacteria, so approximately 100 different ones that have been detected to date, with a minority that are known to cause the majority of pneumococcal disease. And this leads to substantial morbidity, mortality, as well as economic burden worldwide. And then young children, older adults, and those with immunocompromising or other underlying medical conditions are at highest risk of IPD, or invasive pneumococcal disease. And so the burden of IPD in Ontario is highest among older adults. So you can see in this graph here, really showing that increasing trend based on age. So it's kind of this U-shape where we see, higher numbers among those that are younger, and then the highest among those that are in the oldest population. So on the left-hand side, we have the number of cases. On the right-hand side of the graph, we have the rate per 100,000 population. And then you really see that highest number and rate for those 65 plus. So in 2019, about 42% of IPD cases were among adults aged 65 plus, and 85% of these cases were hospitalized. And the reason I'm presenting 2019 data is that we did see a decrease in cases and hospitalizations in 2020 and 2021 due to the pandemic. And of course, that reasoning is multifaceted. We had a lot more stricter measures in place with isolation and as well as masking, etc. And so we saw a decrease, but in 2022, we're seeing that the numbers are coming back to the pre-pandemic levels, so more relatable to what we saw in 2019. So for pneumococcal vaccine, there's actually two types of vaccines available. There's a polysaccharide vaccine and then a conjugate vaccine type. So polysaccharide vaccines, essentially, it's this long chain of sugar molecules that resemble the surface of certain types of bacteria or the antigen, and these help the immune system mount a response. Conjugate vaccine is pretty similar, but the difference is that it joins a protein to the antigen, so this helps induce a somewhat better, robust immune response. And so now we look at that chart at the bottom, and this shows us the different types of pneumococcal vaccines that we have, the actual, manufactured products in terms of the different types of polysaccharide and conjugate vaccines. So right now in use, we have two different vaccines in Ontario. So that's the PCV13 vaccine and the PPV23 vaccine. So on the bottom of the chart, I'll start off with the PCV13 vaccine in the black text. So PCV13 vaccine is a conjugate vaccine. It protects against 13 different serotypes of pneumococcal, streptococcus pneumoniae, essentially. And then below that, we actually have two new conjugate vaccines. These are PCV15 and PCV20. These have both now been authorized in Canada. And so the difference here is now that these vaccines, they actually protect against more serotypes. So PCV15 protects against 2 additional serotypes. So you see that little green highlighted box. And then PCV20 protects against 5 additional serotypes in addition to PCV15. And at the very bottom, we have PPV23. As I mentioned, this vaccine is currently available in Ontario. And this is a polysaccharide vaccine. So this is the only available polysaccharide vaccine. And this protects against 23 different serotypes. And again, highlighted at the bottom, so it protects against basically everything the other vaccines protect against, except 6A, and then it protects against 4 additional. But the polysaccharide vaccines, as I mentioned, typically induce a somewhat lower immune response compared to conjugate vaccines. And so when we're looking at vaccine efficacy, immunogenicity, and safety for these products, so for PCV13, about 75% efficacy against vaccine-type invasive pneumococcal disease among adults aged greater than or equal to 65 years. PPV23 efficacy has been found to be more than 80% against IPD among healthy young adults, but it ranges from about 50 to 80% in older adults and high-risk groups. And then PCV15 and PCV20, there's no data assessing efficacy or effectiveness for these products, but they have been shown to have a similar or superior immunogenic response compared to PCV13 and PPV23. And now when we're looking at safety, so essentially all of the products, the most common reported side effects for these vaccines were injection site pain, swelling, fatigue, headache, low-grade fever, muscles, aches, and pains. And so when PCV15 and PCV20 were authorized, studies were done comparing the safety of these products with the currently utilized products as PCV13 and PCV23 and very similar safety profiles. In terms of serious adverse events, they're rare, and in most cases, there was insufficient data to determine any causal association. So now when we're thinking of recommendations for these products, so a pneumococcal vaccine, it can get quite complicated in terms of recommendations, and so I've tried to simplify it for the population of interest here. So these are recommendations that may apply to long-term care residents, and these recommendations are guidelines that have been produced by the National Advisory Committee for Immunization in Canada. And so once these products, new products are typically authorized within Canada, NACI, or the National Advisory Committee on Immunization, it produces these guidelines in terms of recommendations for the new products for different populations. And so on the left-hand side of this chart, we have the past NACI recommendations for pneumococcal disease. And so this is focusing on, PCV13 and PCV23 vaccines before the new products had come out. And then on the right-hand side, actually as of February 24th, and since these products are now authorized in Canada, NACI came out with new guidelines for the new products. And so I'll go over the past guidelines as well as the new guidelines and just kind of where the differences might lie. And so for adults greater than or equal to 65 years, regardless of any risk factors, any previous pneumococcal vaccination, the recommendation is to receive a PCV23 vaccine. And these are the past recommendations I'm focusing on first. And then for immunocompetent adults aged 18 to 64 years who are residents of long-term care facilities, as well as a number of other potential risk factors that might place them at higher risk for IPD, also recommended to receive a PCV23 vaccine. So I think in summary, what that means is that if in a long-term care home, regardless, to get the person vaccinated against pneumococcal disease. The bottom two rows are just a bit different in terms of recommendation for the product. So if an adult is greater than or equal to 18 years with an immunocompromising condition, and all of the conditions are highlighted within the Canadian Immunization Guide, the recommendation is for one dose of PCV13 and then a dose of PPV23. And the reasoning behind that being, as I had mentioned, that conjugate vaccines have slightly higher immune responses, and we know that people with immunocompromising conditions need a bit more help in terms of developing a robust immune response to the vaccine product. And then the addition of the PPV23 vaccine increases serotype coverage. And then similarly for those with a recent stem cell transplant, it's 3 doses of PCV13 and then 1 dose of PPV23. And on the right-hand side, when we're looking at the recommendations as of February 24th, essentially for most of these, the change is that we are just changing from PPV23 vaccine recommendation to PCV20. So the recommended vaccine for adults when we're comparing PCV15 and PCV20, the 2 new products, the recommendation is preferred product of PCV20 for a number of different reasons. One of the major ones being it covers a number of more serotypes compared to PCV15. And with PCV15, you would be recommended to provide PPV23 along with PCV15. I know it can get a little complicated. And then essentially, really the only difference is when we're comparing the two are the number of doses for those that have an immunocompromising condition in the bottom 2 rows. And then for those 18 to 49, right now, there is no PCV20 recommendation, given that they are waiting for more evidence to come out for this group. And so the status quo would be a dose of PPV23. So how does that translate into what's available in Ontario in our publicly funded pneumococcal vaccination program? So those are the national guidelines that are provided. And of course, now Ontario has to take those guidelines and actually implement them into a program. And so what's offered in Ontario as of today, so those greater than 65, they could receive a dose of PPV23 publicly funded. If you're immunocompetent and 18 to 64 years of age and long-term care resident, then again, a dose of PPV23. And then for Ontario, if you're greater than 50 years of age with an immunocompromising condition, then you would get the dose of PCV13 with PPV23. And then similarly for stem cell transplant recipients, if it's greater than or equal to 50 years of age, then it would be the 3 doses of PCV13 and the dose of PPV23. And so essentially Ontario has not yet implemented the new products into the publicly funded system. Of course, it takes a bit of time in terms of, these guidelines that come out recently in terms of reconfiguring a vaccination program for the province. And so just really wanting to highlight, just because they have not yet been implemented, that the current products they're still, they still should be used, and, residents should still be vaccinated, and even highlighted within the NACI guidelines that they do support the continued use of PCV13 and PPV23 in adults when PCV15 and or PCV20 are unavailable or inaccessible. So now going into COVID-19 vaccines. So very briefly, just going to touch upon, the structure of the vaccines and how kind of they work. And I'm going to focus on the mRNA vaccines, given these are the preferred vaccines and mostly utilized within Ontario. And so essentially what I just want to highlight, I won't go through every little step of the graphics, but how these mRNA vaccines work. There's no live virus that's being put in a person to try to trigger an immune response, but it's rather it's this technology that's really teaching our cells how to make a protein that will then trigger that immune response. So it's that spike protein that we're kind of teaching our cells to then produce that will trigger an immune response. And so this slide, I put this together actually after we had a presentation, I think it was last month now, with a smaller group talking about COVID-19 vaccines. And one of the biggest questions was, we know that COVID-19 vaccines are very important, but the residents have maybe had 6 or 7 doses already at this point, so why do they need another one? So I think it's a really, really important topic to cover, and I wanted to just touch upon that within this section. So, there's 2 really big reasons for this. One of them is that, COVID-19 vaccine doses, they wane over time, the actual effectiveness. And so for severe outcomes, the waning is a little lower, but for infection and symptomatic infection, it's much faster. And so if we focus on these graphs that I brought here at the top, so these are essentially vaccine effectiveness estimates against 3 different outcomes: infection, symptomatic infection, and then severe outcomes. And this is actually taken from a study that we did in Ontario, where we looked at the vaccine effectiveness of 2, 3, or 4 doses of the COVID-19 vaccine among long-term care residents in Ontario with some, so I worked on this with a number of colleagues. And so essentially what we saw was that, there was waning effectiveness. So if we focus on, the time since 4th dose for each of these little graphs, you can really see that reduction across time for these vaccine effectiveness estimates. So that red line really highlighting that decline. So you can see for infection on the very left-hand side, we're going from about 49% with a pretty recent dose of less than 84 days ago to about 18% when we got to about 168 days. For a symptomatic infection, from about 69% to 44%. And then for severe outcomes, about 82% to 74%. Now that decline is a little bit, actually quite a bit less for severe outcomes. But of course, remembering that this population is probably at the highest risk of these severe outcomes. So it's really important for us to, bump up as much as we can in terms of effectiveness for these people, especially given that the very high chance of severe morbidity as well as mortality for this population. And then the second reason really is that, COVID-19 is a very, very highly, changing virus. So we have a number of different subvariants coming out. The landscape is, constantly changing across just a few months sometimes. And so when these new subvariants come out, essentially, our previous vaccine products might not be as effective against these new subvariants. And so, as you may know, we have a new product, which is the XBB.1.5 containing vaccine now in Ontario and Canada, and really, internationally being kind of brought out. And so the reasoning behind that is because we now have, XBB and XBB sublineages, and these are all Omicron sublineages still, emerging over time. And so, our previous product was the bivalent vaccine. And so that bivalent vaccine had different, it was targeting different sublineages. Those were targeting the BA.4/5 sublineages. And so essentially, we need to update our product to make sure that we are, having the best product and best effectiveness that we can give for fighting these newly emerging subvariants. And so, taken directly from the NACI statement, individuals vaccinated with the updated XBB.1.5 containing COVID-19 vaccines, they're expected to benefit from a better immune response against currently circulating strains compared to earlier formulations, and this is based on clinical data, essentially suggesting that the immune response for these vaccines against newer circulating variants that are descendants of the XBB lineage will be better. And so now talking about safety, the Coles Note version of the slide is that the safety is very similar. And this chart is taken from, this one is focusing on just the Moderna XBB.1.5 containing COVID-19 vaccine. And so this is just showing us essentially at the top, the top graph, let's just focus on the yellow because that's the vaccine that we are using, the monovalent XBB.1.5. And we're comparing these percentages that we're seeing to the bottom graph. So we have the original vaccine in the light blue. We have the bivalent BA.4/5 in the dark blue. So as mentioned before, the bivalent BA.4/5 is the product that we were using before. I'm looking at it across a number of different adverse events. So you can see the proportions line up pretty similarly, if not, somewhat lower for the newer product. And essentially, there were no serious adverse events that were reported, but of course, long-term safety is unknown since it is a newer product. And then finally, when we're thinking about, what are the NACI recommendations for fall 2023 for COVID-19 vaccines, as well as the Ontario eligibility. So essentially, vaccination with XBB.1.5 containing COVID-19 vaccine is recommended for those previously vaccinated if they are in an authorized age group for this specific formulation. And then finally, if it has been at least 6 months from the last COVID-19 vaccine dose or infection. And then NACI has also recently released a statement around for those that have been previously unvaccinated. This might be a little bit less relevant for most long-term care residents, of course, but that the latest formulation of the product, the XBB.1.5, also recommended for those previously unvaccinated, and that would be 1 dose recommendation and then an additional dose for those individuals who are moderately or severely immunocompromised. And then finally, that these products, so Moderna has one and Pfizer has one for the XBB.1.5 containing vaccine, and these are available in Ontario for everyone that is eligible as of the end of October. And now I'm going to hand it off to Shelly to talk about influenza.
Thank you, Ramandip, and thank you very much for having us here today. I'll be talking about influenza, RSV, and Zoster vaccines, and Ramandip will be switching slides for me, so thank you in advance. So we're going to start off with influenza. Next slide, please. Thank you. So flu infects about 5 to 10% of adults each season. And before the pandemic, it cost around 12,000 hospitalizations and about 3,500 deaths annually in Canada. We classify influenza in various different ways. Influenza A is classified using 2 different proteins that are on the surface of the virus. One is called hemagglutinin, and that mediates the binding of the virus to the cell. And one is neuraminidase, which helps the virus actually get in. These 2 proteins stick out, and so your body can make a really nice immune response to them, and that is also how we classify them. So when we say influenza A, H1N1, or H3N2, that's really what we're talking about. What kind of H and N proteins are there? For influenza B, it's a little bit different. We classify flu B into 2 lineages, B Yamagata and B Victoria. And each year, prior to the pandemic, each year we would get either all one or all the other or a mix of both. But actually, we haven't seen Yamagata since the pandemic. Which is very, very interesting. So never make any predictions when it comes to flu, but so far we have not seen it since 2020. Next slide, please. Thank you. So this is a figure that shows influenza activity by % positive. So what proportion of tests that we get at the Public Health Ontario labs are positive, and by surveillance week on the bottom. So basically week of the year, and just to orient you, week 40 is the beginning of October. Obviously 52, 53 is end of December, just to kind of show you where we are at. And we see that generally influenza A activity peaks around now, mid-November, and slowly in the beginning of the next year tapers down in the first few months of the year. Next slide. And then we see influenza B happens a little bit later. So it's not uncommon to have two different waves of flu A followed by flu B. And that's also an answer to if individuals are asking whether it's still worthwhile to get immunized even though the season has started. Next slide. Now, this is what happened last year during the triple-demic. We see a really, really high peak of activity that started way earlier than normal in 2022, 2023. And then the lighter bar is what we're seeing this year. So it looks very much like a seasonal kind of pre-pandemic seasonal influenza trend. Right now, we're at about 2.6% positivity at the Public Health Ontario labs. Next slide. And then here, there isn't much flu B activity this year, but this is last year's. We see that conversely to flu A, that was really early, flu B was really late. So last year, because of pandemic disruption, the year was a little bit funky, but so far we are on track to have a kind of a usual flu activity by time. Next slide. Okay. So every year, twice a year, the WHO assesses what is circulating and makes a recommendation about which flu strains should be included in the vaccine. And so for us, for the Northern Hemisphere, they look at what's happening at the Southern Hemisphere and vice versa. So these recommendations for what is in the vaccine for us, the Northern Hemisphere this year, actually came out last, I believe it was February. So a really long time ago, because they're looking at what's happening when in the off season. So it's winter here and summer there and vice versa. And we see one H1N1, one H3N2, and one Victoria lineage. And this is actually quite similar. 2 out of 3 are identical to what was recommended last year. Once the WHO makes this recommendation, this is what goes in. Next slide. So we're going to talk about flu vaccine that's made in eggs. There are other mechanisms to make flu vaccine, like cellular vaccines, but they're not available in Canada. So just in the interest of time, we're not going to talk about them today. Once the WHO chooses the strains, they are grown in fertilized eggs. This takes a very, very long time. It takes about 6 to 8 months to get enough of a supply to vaccinate everybody. And unfortunately, sometimes in the meantime, flu mutates a little bit because flu mutates quite easily. So there's a little bit of a gap between when we decide what to put in the vaccine and when we're actually ready to give the vaccine. And that is why sometimes we miss a little bit with the vaccine match. And from season to season, we have varying estimates. I think in a poor season, it would be 30 to 40% vaccine effectiveness. In a good season, it might be 60 to 70. We always look to the other hemisphere to predict what might happen in our hemisphere, and the Southern Hemisphere vaccine effectiveness estimates for hospitalization in older adults, which is very much the population that you all care for, was 42.7 for flu A and 46.2 for flu B. So kind of medium as flu VE goes. Next slide. Okay. Why is it important for long-term care home residents and other older individuals living in congregate settings to receive a flu vaccine? So this is a fairly messy figure. I'm just going to talk you through it. The main reason that it's important for long-term care health residents to be vaccinated is H3N2, which is one of the 2 types of flu A. Generally, older individuals don't do very well with H3N2 compared to how they fare with H1N1. Flu B is a little bit less of a concern for this age group. 80% of flu cases in Ontarians who are 65 and over is flu A, of which nearly 3/4 of H3N2 is H3N2. So that's what I'm focusing on for this slide. And this slide is showing you hospitalizations per 100,000 on the y-axis and age in the x-axis. And we can see 2 things. First of all, we see that the number of individuals hospitalized, or the rate of individuals hospitalized, goes up with age. So we see once you hit 65, you're more likely to be hospitalized, and then there's a jump to the next age group and a jump to 85 plus. We also see that if you have comorbidities, that really raises the risk of hospitalization. So the bars that are dark are individuals with comorbidities, and the bars that are light are individuals that are not. And you can see, even if you're vaccinated and you have comorbidities, you are still, more at risk than if you didn't have them. All in all, an individual who is 85 years or older and is vaccinated and has a comorbidity has a 1 in 70 chance of being hospitalized, compared to about 1 in 56 for individuals who are high risk and not vaccinated. So that would be several people a season in some congregate settings. In individuals who are 85 years and healthy, vaccines lower the risk of hospitalization by 65% for H3N2, which is quite substantial. With individuals that have comorbidities, it's a little bit more modest, lowers the risk of hospitalization by 23%. But certainly we see here that the conflation of age and comorbidities makes this population at risk in a very different way, and a much more serious way than other populations. Next slide. So the influenza vaccines in Ontario, there are 3 that are available for the congregate setting, 65 and over population. It's the high dose or the adjuvanted vaccine. So both of these are administered to individuals who are 65 years and older. The high dose vaccine has 4 times the dose of the regular vaccine, and it has been shown to protect better than the standard dose. The adjuvanted vaccine has an adjuvant, which is an extra thing that is added to the vaccine to produce a better immune response. We know it is better than unvaccinated than not being vaccinated, but sadly, there's no head-to-head comparison of high dose versus adjuvanted flu vaccine. So we can't really compare between them. And it's my understanding that one vaccine or another gets sent to a congregate setting. Both of them are better than not being vaccinated, and it's safe to say both of them for this population are better than standard dose. Next slide. So vaccine adverse events, so local events or systemic events happen for flu more commonly in females, more commonly in younger individuals because our immune response isn't as robust as we age, and also those with a respiratory infection. So if you've ever heard the flu vaccine gave me the flu, that is because when we get flu vaccine, we also have a lot of other respiratory infections that are circulating. Both of the high dose vaccine and the adjuvanted vaccine are very safe. For the high dose flu vaccine, there's more systemic reactions, and that makes sense. You're getting 4 times the dose of the standard vaccine. However, serious events are very uncommon, and they're at the same rate as the standard dose. So very safe vaccine. The adjuvanted vaccine, as you would think, the big thing is local reactions, because you have that adjuvant in there that's being injected into the arm. But it's, same thing, very uncommon to have serious reactions and very comparable numbers to non-adjuvanted. And I think most of you know that flu and COVID-19 vaccines can be co-administered. Next slide. Okay, moving on to RSV. Thank you. Respiratory syncytial virus, or RSV, has, it's another one of these winter respiratory viruses. We see that activity peaks more or less at the same time as flu, maybe a little bit earlier, and also drops off a little bit earlier too, around March. Next slide. And here we see last year, the triple-demic, RSV in the triple-demic was quite pronounced. And then in the lighter line, we see the data for this season, and we see that we're actually on track so far to have a similar season. So lots of RSV activity around already. Next slide. So why is it important? This is a new vaccine. I imagine you have a lot of people asking you questions about why it's important for long-term care home residents to receive this vaccine. RSV has historically been underdetected, and we haven't paid as much attention to it as we should. But in fact, it has very similar symptoms to flu, except for fever. The onset is a little bit slower, which from an infection control perspective can sometimes be an issue because you might not realize it as quickly. It is more contagious than flu and is contagious even before symptoms appear. And sadly, it unfortunately sometimes results in increases in either severity of comorbidities or frailness. For hospitalization, it's less hospitalization than flu, but often a longer admission duration. But the mortality rate is similar to influenza in older adults, and things like older age, residence in a congregate setting, and various comorbidities. But chronic kidney conditions and diabetes happen to be the two that really predisposed people are associated with the 30-day all-cause mortality. On the right, we have a table that basically shows that while the majority of individuals that are hospitalized for RSV are young, they're between ages 0 to 4, individuals who are 65 and older make up 85% of the deaths. And so that really nails it home. This is a very, very serious disease for this population. Next slide. So as you likely all know, we have a new vaccine called Arexvy. It's a subunit vaccine that uses a protein, again, from the outside of the virus. It is one dose that's administered in IM, and it is approved in Canada for individuals 60 plus. And we see that it has very, very good vaccine effectiveness against severe lower respiratory disease, any lower respiratory disease, or acute respiratory infection. So the data that we're showing here is from the clinical trial. And after one season, you see that the vaccine effectiveness is very, very good, very robust. And then there are also some data for after 2 seasons, which is an 18-month follow-up. And you see that vaccine effectiveness drops a little bit, but it's still fairly good. Next slide. Safety. Very good safety profile. Most adverse events were mild and resolved quickly. Once again, this is an adjuvanted vaccine, so it's not shocking to know that injection site pain was the most commonly reported reaction. So this is definitely something to expect after being given vaccine, and fatigue was the most common systemic reaction. Serious events, again, were rare and similar to placebo. And since this is a new vaccine, there are currently trials to look at the effectiveness, so the safety and the effectiveness of co-administering this vaccine with other vaccines like flu or PCV20. Next slide. So eligibility and logistics. So in Ontario, the vaccine is available for individuals who are 60 plus years who live in long-term care homes, elder care lodges, and some retirement home residents. From a regulatory perspective, it's approved for anybody who's 60 and over. So if you're not in those populations, you can also purchase the vaccine with a prescription. Now, we recommend that at this point, RSV vaccine is not co-administered with influenza or COVID-19 vaccines. It's a new vaccine. We want to make sure that if there is an adverse event, we know which of the 3 we would attribute it to. However, there are some scenarios where you could co-administer, like, for example, if it's, you're not going to see the person again, then you can give all 3 together. If you see that community activity is increasing, so right now COVID activity and RSV activity is high, or if there's an outbreak in the facility or in the geographic region. Next slide. Okay, one more. I'm just mindful of the time. Herpes zoster or shingles. Basically, this is a reactivation of the chickenpox virus. After we have chickenpox, the virus actually lives in our nerves and stays there in a latent state. And sometimes it comes out again as shingles, which is a painful rash or small blisters on the skin, often on one side. And it can be very, very uncomfortable. And it's also very, very common. It occurs in 1 in 3 Canadians in their lifetime. And in addition to shingles being uncomfortable, the complications of shingles are very common too. So most commonly postherpetic neuralgia, which is a nerve pain that continues after shingles due to nerve damage from the infection. And it can last for a very, very long time and be incredibly painful. Also, other things like nervous system disorders, other infections, and other manifestations that are quite painful and serious. Next slide. So this figure, I think, shows very well why individuals who reside in long-term care homes should receive a zoster vaccine. So on the y-axis, we have zoster hospitalization rate, and on the x-axis, we have age in years, and we have data from various provinces. And we see that somewhere between age 45 and 50, there is an inflection in the slope of this figure, and your risk of zoster goes up. In fact, 2/3 of cases occur in individuals who are over 50, particularly so in individuals who are older or immunocompromised. They are at greatest risk for shingles and for shingles complications. Next slide. So historically, we've had a vaccine called Zostavax, which is a live attenuated vaccine. And then about 5 years ago, a new vaccine came on the market called Shingrix. So in the interest of time, I'm only going to talk about Shingrix, but happy to go through the other one in the questions. So this is, again, a subunit vaccine. So it's got a protein that is included in the vaccine, and it has an adjuvant. So this is the same adjuvant that is in the RSV vaccine, but there's twice as much of it. And we're going to see the effect of that when we look at local site reaction. So a lot of adjuvants approved for anyone over 50, and it's 2 doses, 2 to 6 months apart. And we see that unlike the old vaccine, the vaccine effectiveness is very, very high, and it stays high over years. So it doesn't decrease. It's good for a long time. There isn't a lot of information on co-administration, but because it's not seasonal, there may not be the need to. Next slide. So Shingrix is very immunogenic. So because of this adjuvant, it's going to hurt your arm. So someone anecdotally told me they couldn't lift their arm after zoster vaccine. In the phase 3 clinical trial, 82% of recipients reported some sort of a local reaction. This is normal and part of being vaccinated with Shingrix, but is certainly better than having zoster. A lot of individuals also reported mild systemic reactions, so things like headache or myalgia, but the serious adverse events were rare, and they were exactly at the same rate as the placebo. Next slide. So recommendations. The National Advisory Committee for Immunization makes these national recommendations, and they say that Shingrix should be offered to anyone who's 50 years and older, even if they've had shingles before, even if they've previously been vaccinated with the old vaccine, Zostavax. And then if they're immunocompromised, there is a lack of data on Shingrix in immunocompromised individuals, so on a case-by-case basis. For individuals who are immunocompetent and cannot have Shingrix, they can consider Zostavax, which is the old vaccine. However, it is a live attenuated vaccine, so you absolutely can't have it if you're immunocompromised. Next slide. Now, NACI is the one that makes the recommendations, and as Ramandip said before, Ontario has to make a policy that goes along with these recommendations. And so in Ontario, Shingrix is publicly available for individuals who are between 65 and 70, but who have not previously received Zostavax through the publicly funded program. So basically, the province is willing to pay for it once. There are individuals who missed their chance because of COVID, so those born between 1949 and 1952, and they kind of have an extended time period to complete the 2-dose series by the end of the year because the government recognizes there was a delay there. And then individuals who are not eligible provincially through the routine program can purchase Shingrix with a prescription. Next slide. Okay. I think we still have 12 minutes for questions, which is great. Here are some helpful resources. The Canadian Immunization Guide is always a really great place to go if there are any questions. I look at it probably at least once or twice a week. Public Health Ontario has a respiratory virus tool that tells you in real time. It's kind of a dashboard showing what's happening in the province. And the National Institute on Aging has a lot of wonderful resources about RSV and about immunization in older individuals. That's it. Thank you for your attention.
Okay, fantastic. Thank you, Ramandip, and thank you, Shelly. That was really great. If you don't mind, everybody give them a little round of applause with your Zoom emoji. So really, really appreciate your time and putting that together. This is really fun, and I learned a lot in this in your lecture. And if you guys don't mind, I'm going to jump right to the questions. So 12 questions have been posed, and why don't we tackle some of the most the ones that have been upvoted the most. So the first question was, when is the RSV vaccine available?
So I will take that one and Ramandip can jump in. It's my understanding that it has started to be rolled out now, but I don't think that everyone has it quite yet. I think they have started the process though. Ramandip, is that your understanding?
Yeah, that's also my understanding that they're being rolled out now, and more recommendations coming out for long-term care facilities as well.
Great, fantastic. Okay, number 2. Is it safe to administer pneumococcal and Tdap vaccination to newly admitted residents who have no evidence or record of receiving said vaccines?
Yeah, I'm happy to start with this one. So, I mean, even in the National Advisory Committee for Immunization, their guidelines, I'm talking specific to pneumococcal, and I would assume the same for Tdap. Essentially, the recommendations are highlighted as, if the person has been previously unvaccinated or if their vaccination status is unknown. So if unknown, it's, safe to give the vaccine to the individual. It's better to get vaccinated than, to be unsure and then not give the vaccine.
Great. Okay. Anonymous asks, how long should I wait before administering influenza vaccine to a COVID positive resident? Should I wait until they're recovered?
I can start with this one. So I think that this would just fall under, if individuals are acutely unwell, we generally wait a few days until vaccinating them. So if they have a mild cold, that's one thing. But if they're acutely unwell, then definitely worth waiting until they're recovered.
Okay, fantastic. Anonymous asks, if a resident is unvaccinated against flu and acquires influenza, can they still receive the flu vaccine? At times, the power of attorney will consent after the resident has acquired infection.
This is a great question. So if someone is acquiring flu before they get vaccination, the flu season continues over time. And so even if you had H1N1, you may get H3N2 or you may get influenza B. It certainly is definitely still worth getting immunized.
Great. All right. Should I be offering pneumococcal vaccines for residents on admission to my LTC?
It's a really great question. I think the first step would just be to get an idea of what their vaccination history looks like. So, maybe they've been admitted a little later in their lives and they've already received the pneumococcal vaccine after they turn the age of 65. In that instance, if that is known, they don't need another dose. But of course, as we talked about previously, if there's absolutely no information on their vaccination history and it's just unknown whether they've received the pneumococcal vaccine, then at that point you could give the vaccine. But I think it's a great idea in terms of like starting the discussion when they're admitted to get an idea of what their vaccination history looks like.
Great. Okay. Should we still offer these immunizations to residents who are under palliative care, not end of life? Some powers of attorney, substitute decision makers refuse to give consent for residents in palliation.
Ramandip, why don't you take this one? Because we've had this question before and I think you had a great answer.
Sure. So we actually, last time we had this presentation, it was really not even just a question. It was like an amazing discussion with a lot of the IPAC folks kind of giving their feedback as well, which I thought was super, super amazing. Essentially, these immunizations, like in my opinion, and, I think a lot of others' opinions, and Shelly as well, like we all talked about it, that at the end of the day, if the person is eligible for the vaccine, that they should receive the vaccine. And of course, kind of thinking of it through in terms of like the season, like if it's not influenza season, they probably don't need the influenza vaccine, but if it is, you should probably give it to the individual. At the end of the day, we want to prolong the person's life as long as possible. And if a vaccine is able to do that, then, it's probably recommends that we should be giving them the vaccine. Of course, if the person is refusing consent, that is a different situation. In that case, you can give the vaccine because they're saying no, and the power of attorney is saying no. So it, of course, will end up becoming more of like a case-by-case basis. But if the family or whoever the power of attorney is pro-vaccine, then I would say give them the vaccine.
Okay, fantastic. For the shingles vaccine, how long should I wait to administer to a resident who recently had shingles?
Okay, that one is mine. The recommendation is that you wait 1 year after the shingles episode to administer vaccine.
Great. I think I remember that from the presentation. Okay. For a resident who recently was infected with RSV, can we give the RSV vaccine right away, or do we wait for a certain period?
So for RSV, there isn't the same kind of recommendation as for COVID, where if you've had COVID, you should wait a certain amount of time. That doesn't exist for RSV. So I think my logic would say that you do the same thing as the previous question for flu. Wait until the person is well enough, and then you can administer.
Great. Okay. Preet asks a question here. It looks like these two are kind of related, so I'm gonna clump them into one. Can you guide us for pneumococcal booster dose? If a resident has already received pneumococcal vaccine at the age of 70 and is now admitted to long-term care at the age of 80 years, does he or she need a booster for pneumococcal?
So there's no recommendations for like the regular routine program in terms of booster doses for pneumococcal disease. So if the person and that's essentially like talking about the person doesn't have like an immunocompromising condition. So if they've had it at 65 or after, they're probably okay. But there are recommendations if the person is, immunocompromised due to a condition. And we know that a lot of, long-term care residents could potentially have a lot of comorbidities. So the Canadian Immunization Guide, they actually list the different conditions in terms of who might be at like high risk versus highest risk. And so this group around severely immunocompromising conditions, for example, HIV, sickle cell anemia, or yes, I think those are some of them. I had a list of some of them too. Solid organ transplant or taking immunosuppressive therapy. In some of those conditions, then it is recommended to receive another dose of pneumococcal vaccine, and the interval, I believe, is 5 years. But again, I would double check the Canadian Immunization Guide just to make sure that they're based on their specific condition if they would be eligible for a booster, and then as well as the interval. And then I would also, of course, look at the Ontario guidelines, which are available online in terms of if they would be eligible and publicly funded to receive that booster.
Great. And I'm just thinking out loud that if you have a specific case in your long-term care home and you have a question about this immunization, you can always reach out to your local IPAC hub. They can help you navigate these resources that Shelly and Ramandip are talking about to make that decision. Okay. For individuals who are recently recovered from influenza, what is the recommended interval to receive their influenza vaccine? Is it similar to COVID? So this is a similar question, I think, Shelly, what we've asked before.
I'm happy to go through it again. So it is not similar to COVID in that as soon as the individual has recovered, you can give them influenza vaccine. And in fact, it would protect them against the other strains that they did not have. So it's definitely good practice.
Okay. This is a question posed by Preet that I actually agree. I'd like to know too. So why do adjuvant vaccines cause local pain?
Yes, this is a great question. So an adjuvant is an extra thing that we put in vaccines that makes an immune response, but it's not actually vaccine antigen. And what happens is that it gets injected into your muscle, let's say your shoulder muscle, and it sticks around. The adjuvant gets into your muscle and it hangs out there, and your immune system says, oh, wow, there's something in my shoulder. I better go check it out. And so you get an immune response towards that adjuvant. But in the meantime, that antigen is there as well, that vaccine antigen. And that is how you make a better immune response in adjuvanted vaccinations. When we have a cellular immune response directed towards an adjuvant that is, let's say, in your deltoid, that is what causes that local pain.
Okay, fantastic. And I'm just being conscious of the time. We'll take the last question here. If a resident has received a bivalent COVID vaccine in July or August, how long before they can receive the new monovalent?
So the recommendation, if they have not yet received the XBB monovalent vaccine, is 6 months to go then receive the XBB monovalent vaccine. There were some like very, very high risk conditions that are again outlined in these documents where they said that if you talk to your medical professional, potentially 3 months, but the current, for the wider population, it would be wait 6 months, and then they can receive the XBB vaccine.
Fantastic. Okay, so we're at 3:30, and I want to be respectful of everyone's time. So I wanted to say thank you to the two of you. This was really, really helpful. I know that this is something that is a topic at the top of mind of a lot of IPAC leads in long-term care, and just want to say thank you again for specifically tailoring this vaccine for IPAC leads in long-term care, retirement homes, and congregate living settings. It's a group of healthcare professionals that are doing really great work and deserve this time and attention. So thank you so much.
Thank you for having us, and thank you for everything that you do.
Yeah, ditto. Thank you so much.
Okay. Goodbye.